Introduction. Glaucoma is a chronic eye disease in which pressure buildup, intraocular pressure, or IOP, damages the optic nerve, leading to vision loss. Standard treatments focus on lowering IOP by helping fluid drain out of the eye or reducing fluid production. In 2026, several new clinical trials are testing novel approaches beyond the usual medications. These include drugs and devices that enhance outflow, suppress inflow, prevent scarring, antifibrotics, protect the optic nerve, neuroprotective, and improve blood flow to the nerve, vascular modulators. Each strategy has a clear laboratory rationale and often positive early human data. For example, nitric oxide donating prostaglandins like NCX470 and Rho kinase ROCK inhibitors aim to widen the trabecular meshwork or veins to enhance drainage. Neuroprotective strategies such as high-dose vitamin B3 or GLP-1 agonists have shown in animal models that they can preserve retinal nerve cells even without pressure changes. Below we summarize each mechanism, its rationale, early evidence, and how trials measure success, e.g., IOP patterns, nerve imaging, or visual fields, along with key safety issues. Outflow enhancers. What it is. These treatments aim to improve fluid drainage through the eye's natural outflow channels, trabecular meshwork, and Schlemm's canal, or add new paths. Enhanced outflow lowers IOP without directly reducing fluid production. Examples include new eyedrop drugs and micro-invasive surgical devices. Rationale, preclinical and early data. Preclinical studies show that relaxing the trabecular meshwork or dilating outflow veins can dramatically increase fluid outflow. For instance, ROCK inhibitors like netarsudil relax cellular tension in the drainage tissue. In clinical trials, they lowered IOP as well as timolol, a gold standard medicine. Another example is QLS-111, an ATP-sensitive potassium-channel opener that dilates veins and may reduce the downstream pressure on Schlemm's canal. In Phase 2 human trials, QLS-111 added to latanoprost dropped IOP by several mmHg. Device approaches, like suprachoroidal implants or laser trabeculoplasty, physically widen or reopen drainage channels, and early studies in animals and humans show pressure falls and improved outflow on imaging. Earlier trial results. A recent Phase 3 study, NCX470, and others confirmed that combined outflow enhancers can beat traditional drops. For example, NCX470, a bimatoprost nitric oxide donor, lowered pressure more than latanoprost at multiple time points in trials. In summary, these agents demonstrated significant IOP reduction in controlled studies, supporting their mechanism of increasing outflow. Primary endpoints. Trials test the IOP lowering effect directly. Typical primary endpoints include mean IOP reduction and diurnal 24-hour IOP profile. For example, studies often measure IOP at 8 a.m., 10 a.m., and 4 p.m. on several follow-up visits. A true outflow enhancer should show extra pressure drop, especially in the daytime trough, or reduce the difference between peak and trough pressures, reflecting improved drainage. In some trials, outflow facility or drainage imaging, e.g., canal angiography, may also be assessed. Safety endpoints monitor vision and eye examination. Safety considerations. Outflow drugs commonly cause ocular redness, conjunctival hyperemia, and light sensitivity because they act on blood vessels and nearby tissues. In pooled studies of netarsudil, a ROCK inhibitor, over half of patients had mild transient red eye. This is expected and usually tolerable. MIGS devices or lasers carry risks of mild bleeding, hyphema, and short-term pressure spikes, so protocols watch IOP closely after surgery. Systemic side effects are generally minimal, but care is taken to avoid very low pressure, hypotony, in the first weeks. All trial protocols include monitoring for inflammation or infection. Inflow suppressors, what it is. These approaches reduce aqueous humor production by the ciliary body, the tissue that makes fluid. Traditional inflow suppressors include beta blockers and carbonic anhydrase inhibitors. New strategies under study include innovative delivery systems, e.g., implants or injections of these or similar agents to improve duration and compliance. Rationale, preclinical and early data. Laboratory research confirms that slowing ciliary fluid generation lowers pressure. For example, continuous release formulations of timolol, a beta blocker, placed inside the eye have shown stable IOP lowering in animal models and early human tests. Sustained-release implants maintain effective drug levels far longer than a drop, overcoming the problem of poor adherence. No novel molecular inflow target has emerged recently beyond the known pathways, so most innovation is in delivery, sustained release, or combination approaches. Earlier trial results. ID Pharma's Timo-D implant is a proof of concept. In a phase 1 human study, a tiny biodegradable implant releasing timolol was safely inserted, often at cataract surgery, and produced a consistent modest IOP reduction over months. The follow-on trial results showed that patients could maintain lower pressures with little need for extra drops. Other devices, e.g. slow-release dorzolamide rings or micropumps, are in early phases. So far, early human data support that these implants safely suppress fluid production as intended. Primary endpoints. The main efficacy measure is again mean IOP reduction over time. Some studies look at the percentage of patients maintaining target IOP at 6 or 12 months without additional medication. In trials combining an inflow implant at cataract surgery, the endpoint might be post-surgical IOP versus control. Diurnal IOP could also be measured, similar to outflow studies. If the implant is meant to last a year, researchers may focus on IOP at 6 and 12 months as primary data points. Safety endpoints include corneal and anterior segment exams to check the implant placement and heart respiratory monitoring to catch any systemic drug absorption, particularly for beta blockers. Safety considerations. Because these agents act on the eye's fluid pumps, they can rarely affect the whole body if absorbed. Protocols watch for cardiovascular effects, e.g. slowing of heart rate by beta blockers. Local side effects include eye irritation or blurred vision, which are tracked. Stinging or surface irritation from the implant is also possible. Trials include slit lamp exams at each visit. Importantly, sudden device failure, e.g. implant migration or breakage, is monitored. So far, published trials report good tolerability with these sustained-release devices. Antifibrotics, anti-scarring agents. What it is. Antifibrotic therapies are given around the time of glaucoma surgery, or even with some MIGs, to prevent scar tissue from closing the new drainage pathway. Standard drugs like mitomycin C, MMC, are toxic cytotoxins. Newer agents aim to block scarring in a more precise way, ideally with fewer side effects. For example, siRNA molecules that silence fibrosis genes like MRTFB are being tested. Rationale, preclinical and early data. Scarring of the conjunctival bleb or drainage channel is the main cause of surgery failure. Researchers have identified cellular pathways, like the MRTF transcription pathway, that drive fibroblast proliferation. In lab models, blocking MRTF prevents scar formation. One report found that a novel MRTF inhibitor prevented scar tissue as effectively as MMC in a rabbit eye model. Similarly, early studies of an siRNA targeting MRTFB ECP105 in animal glaucoma filtration models showed a 30% decrease in scar markers. These studies provide strong preclinical evidence that targeted antifibrotics can reduce post-surgical scarring without widespread cell death. Earlier trial results. Most antifibrotic approaches are still preclinical, but a few human trials have started. For example, new small molecules or antibody fragments against TGF-beta, another fibrosis factor, are in early safety trials. A clinical trial in Asia used a new IOP-lowering drop with anti-scarring activity and reported less conjunctival fibrosis at 6 months, an early human hint. These emerging data suggest that antifibrotics can improve surgical outcomes without the high complication rates of older drugs. Primary endpoints. Trials tend to use surgery success rates as endpoints. This might mean the proportion of patients maintaining open filtration, bleb, with controlled IOP at 6 or 12 months without additional medication. In some studies, success is defined by IOP target, e.g. 15 mmHg, or by the need for drop-free control. Imaging of the bleb via OCT or slit lamp grading is often a secondary endpoint to quantify scar tissue. Some trials also measure the rate of reintervention, need to reopen or revise the bleb, as a proxy for fibrosis. In all cases, protocols carefully monitor hypotony, too low IOP, and bleb leaks, since aggressive antifibrosis can overbalance drainage. Safety considerations. Classic antifibrotics like MMC reduce scarring but cause complications: leaking blebs, flat, cataract-inducing hypotony, infection risk, and endophthalmitis. Newer agents aim to avoid these. Trial protocols include frequent exams for leaks, low pressure, and retinal evaluation. If siRNA or small molecule inhibitors are used, systemic exposure is minimal. They are injected locally, but local inflammation or allergies are watched for. Safety protocols also require measuring endothelial cell health and vision, since corneal damage can occur if the drug spreads. In published animal models, MRTF inhibitors did not show extra toxicity, making them a promising, safer class. Neuroprotective strategies. What it is. Neuroprotective treatments aim to preserve optic nerve fibers and retinal ganglion cells independent of IOP. This can include metabolic therapies, growth factors, or neural signaling modifiers. Examples in 2026 trials include high-dose vitamin B3, nicotinamide, diabetes drugs, GLP-1 agonists like semaglutide, L-type calcium-channel blockers, and novel neurotransmitter modulators. The idea is to boost the eye's resistance to glaucoma damage, so even if some pressure remains, the nerve survives. Rationale, preclinical and early data. Lab studies repeatedly show that interventions like nicotinamide, vitamin B3, or GLP-1 drugs improve retinal neuron health in glaucoma models. For instance, one rat study found daily semaglutide delayed pressure rise and protected retinal neurons in ocular hypertensive eyes. Similarly, nicotinamide, a precursor of cellular energy cofactor NAD, restored intraretinal function in a small human trial of glaucoma patients. Another drug, BL1107, a new alpha-2 agonist, is thought to enhance nerve cell survival. Early human data suggest BL1107 improves visual field sensitivity beyond what timolol achieves. These findings gave rise to neuroprotection trials in humans. Earlier trial results. So far, dedicated neuroprotection trials have been small or ongoing. The perfuse endothelin antagonist, PR001, see next section, was the first to show better visual field and nerve imaging results in treated glaucoma patients. A few other pilot studies, like memantine in the past or brimonidines' neuroeffects, gave mixed results, so current trials often combine neuroprotectives with IOP lowering. Notably, a phase 2 of high-dose nicotinamide reported improved intraretinal function on electrophysiology, and longer-term nicotinamide studies are now enrolling. These suggest human eyes can respond to metabolic neural support in line with the protective hypothesis. Primary endpoints. Neuroprotection trials cannot rely solely on short-term IOP change. They focus on measures of nerve structure and function over time. Primary endpoints often include rate of visual field progression and OCT retinal nerve fiber layer (RNFL) thickness. For example, the Perfuse trial measured visual field sensitivity and OCT RNFL thickness at 6 and 12 months. A successful neuroprotective agent might be expected to slow thinning of the RNFL or reduce the loss of visual field sensitivity over time. Some trials also use electrophysiologic tests, pattern ERG, or optic nerve head blood flow as endpoints. Because nerve damage progresses slowly, typical study durations are 1 to 2 years. Safety considerations. These agents are systemic or ophthalmic, so their side effects vary by class. High-dose vitamins, like nicotinamide, can cause flushing or stomach upset. Trials monitor liver function for metabolic drugs. Neurotrophic factors delivered in the eye, e.g. ciliary neurotrophic factor implants, require surgery, so injection-related issues, infection, retinal detachment, are watched. Blended agents, like BL1107, are topical and generally well tolerated. Trials include checks of blood pressure or heart rate in case systemic absorption occurs. A special concern is that some neuroactive drugs could affect retinal blood vessels or intraocular inflammation, so protocols include regular slit lamp exams and retinal imaging. In published trials, e.g. Perfuse, the neuroprotective implant was reported safe and well tolerated during 6 months, but long-term monitoring remains critical. Vascular modulators. What it is. These therapies target the blood flow to the optic nerve head, aiming to improve circulation in glaucomatous eyes. Glaucoma is linked not only to pressure but also vascular factors. Poor perfusion may contribute to nerve damage. Vascular modulators include drugs that dilate ocular blood vessels or block vasoconstrictors. A leading example is an endothelin receptor antagonist implant, PR01 by Perfuse, designed to increase optic nerve blood flow. Rationale. Preclinical and early data. Eyes with glaucoma often show reduced optic nerve perfusion. Endothelin is a natural molecule that constricts blood vessels. It is elevated in glaucoma. In animal glaucoma models, blocking endothelin locally increases optic nerve blood flow and can protect nerve cells from dying. In early trials of PR001, treated eyes showed about a 10% increase in nerve blood flow compared to untreated eyes, which correlated with better visual field stability. These results provide a strong rationale that improving perfusion can be neuroprotective. Earlier trial results. In a Phase 2A human study of PR001, patients received one intravitreal implant and continued their usual IOP-lowering drops. At 6 months, the PR001 group had small but consistent improvements in visual field sensitivity and OCT RNFL thickness, whereas control eyes tended to worsen. These outcomes go beyond pressure lowering, suggesting a true effect on nerve health. Importantly, the trial reported that the implant raised blood flow as intended, validating the mechanism. Such results are encouraging enough that a larger Phase 2B trial is planned. Primary endpoints. Vascular trials often use endpoints similar to neuroprotection trials, since the goal is functional preservation. Key measures are optic nerve imaging and visual fields. The Perfuse study explicitly included visual field change and OCT RNFL thickness as registrable outcomes. Because the mechanism does not primarily lower IOP, pressure was a secondary measure. Some vascular trials also directly measure blood flow using OCT angiography or Doppler as a proof of mechanism endpoint. In general, expected proof of concept endpoints for this class are slowed RNFL loss or stabilized visual field over time. Safety considerations. Most vascular modulators are administered by injection or implant to act inside the eye. Therefore, they carry the usual risks of intraocular procedures: inflammation, infection, endophthalmitis, bleeding, or retinal detachment. Protocols require careful follow-up exams and retinal imaging after injection. Another concern is systemic effect. Blocking endothelin systemically could affect blood pressure, so patients' vitals are monitored. In the reported glaucoma implant trial, PAR-R01 was safe and well tolerated through 6 months, with no serious ocular events attributable to the device. Still, long-term effects on retinal vessels and perfusion are watched closely. Conclusion. In April 2026, a wave of clinical trials is exploring new therapeutic mechanisms for glaucoma beyond simple IOP reduction. These include drugs and devices that enhance natural drainage outflow channels, blockers of aqueous production delivered in long-acting forms, targeted anti-scarring agents, and innovative neuro and vascular protective strategies. Each approach is grounded in sound laboratory evidence, animal or cellular models, and increasingly promising human data. Trials have chosen endpoints that match the mechanism. Outflow enhancers focus on IOP curves and drainage metrics. Antifibrotic studies focus on surgical success and need for reoperations. And neurovascular agents focus on nerve imaging, OCT RNFL, and visual field preservation. Safety is carefully monitored within each class. For example, outflow drugs are checked for eye redness and hypotony, antifibrotics for leaks and infections, and injection therapies for inflammation. These novel trials hold real promise. If successful, they could reshape glaucoma care by offering patients better pressure control with fewer daily drops, longer-lasting treatments, and even protection of vision beyond pressure effects. Patients should discuss with their doctors the possibility of participating in such trials or trying new therapies when approved. The future of glaucoma treatment is moving toward multi-pronged care, combining safer scarring prevention, improved drainage, and direct nerve protection to keep vision safe. All links to sources are available in the text version of this article. You can find the full article at visualfieldtest.com. Thanks for listening. To check your visual field, click the link at the bottom of this article or visit visualfieldtest.com.